All right, so good morning. For those of you who don't know me, my name's Joseph Cheung. I'm one of the anesthesia residents here at the University of Alberta. And today I'll be presenting on medication errors in anesthesia. So just to preface before I talk about kind of the objectives of my talk, I'd like to give some context. This was a paper published in 2001 by Dr. Orser and her colleagues from Sunnybrook in Toronto. It was basically a survey study where they mailed approximately the 2,200 members of the Canadian Anesthesiologist Society, asking them about drug errors in their practice, and approximately 30% of them responded. Around 85% of them said that they experienced at least one error or with drug administration or near miss in their practice. This basically was a drug error that was caught before given to the patient. 98% of these drug errors were of minor consequence, but 4 deaths were reported. So certainly drug errors have consequences for patients. This was a case report from Anesthesia Analgesia in 2009 from Iran. Basically, this group of physicians reported a case where tranexamic acid was given instead of bupivacaine into a spinal, and the patient developed seizures and status afterwards. They did okay, but needed quite a bit of resuscitation. This picture just shows the vials of bupivacaine and tranexamic acid that they use over there, so very similar. I'm also a statistic of drug error as well. When I went through my GP anesthesia training around 4 or 5 years ago, I inadvertently gave a tenfold drug error to a neonate undergoing a major surgical procedure. So thankfully there was no major sequelae from this. And I'm not sure where Vanessa got the picture posted today. I didn't pick that out, but certainly that's how I felt afterwards for several days at least. So certainly I was impacted, but maybe some of our colleagues have been as well through the CMPA. This was data that was published in a paper in CJA in 2004, basically looking at closed legal actions against anesthesiologists between 1998 and 2002. It looked at kind of the reasons for the anesthesia-related critical incidents, and if you can see here, medication errors formed the large majority of these legal actions. And of course, there's a large economic cost to medical error. This paper down below estimates that approximately per year, $17 billion are associated with medical errors. What proportion of medical errors were medication administration errors, I'm not entirely sure, but certainly there's probably a large proportion of it. So certainly there's impact in terms of patient morbidity, mortality, and both personal and professionally, as well as financially to the healthcare system. So I'd like to go over the objectives of my talk today. Basically, I'd like to explore some of the data looking at the incidence of perioperative medication error. This is a very difficult area of study, and I'd like to go through some papers looking at that. I'll explore some of the factors that potentially may be associated with increased risk of medication error in the anesthetic period, as well as look at some consensus statement and guidelines that people have tried to come up with to try to reduce these events. So first of all, some definitions. What is a medication error? Medication error can basically be defined as a failure to complete any of the required actions in any of the stages of medication administration. And so these stages of medication administration are listed on the screen there. And basically it starts from the point of requesting the medication or ordering the medication all the way to the end where we monitor. So for example, if a physician were to order a dose of opioid for a patient, that would be requesting the medication. Subsequently, that medication is dispensed either from the pharmacist or from Pyxis. And then the physician or whoever would prepare the medication by drawing it up or diluting it, and then subsequently administer it to the patient, or the patient would self-administer that medication. And finally, documentation of both the dose, the time, and the route of the medication, any complications, and subsequent monitoring. So you can have deficiencies in any of these stages of medication administration, and it would be defined as an error. Not all medication errors will lead to an adverse drug event. Some may be minor and have no consequence at all. So an adverse drug event is different. It's defined as basically patient harm or injury due to a medical intervention related to a drug, regardless of whether an error in medication process occurs. So you can get adverse drug events without medication errors. For example, if you gave a person penicillin and developed an allergic reaction without a known previous allergy, that could be defined as an adverse drug event. Some of the challenges for us in anesthesia is that we must perform all stages of medication administration. So there's lacks of checks and balances that a traditional ward may have. For example, on the traditional ward, a physician may order a certain dose of medication. That gets faxed down to pharmacy, and they check that. And that gets faxed back up again with the medications. And then before administration, the nurses will double check that as well. So there's checks and balances to prevent error. We also work in a fast-paced, high-pressure environment in the operating room, as well as many of the medications we use are high-alert medications, potential for harm. So all that makes not only medication errors potentially more likely, but also potentially with more likelihood of resulting in an adverse drug event. And finally, our training models often quite different compared to other health professionals who administer medications, such as nurses. They go through very rigorous training in how to administer medications, the rights of medication administration, and so forth. Whereas a lot of us as residents, we learn on the job and kind of go through basically very informal training through learning through other preceptors. So what's the incidence of medication errors in anesthesia? This is a very difficult thing to study. This is a table from a review article in 2013. It basically summarizes the large studies that have been quoted in the anesthetic literature looking at medication errors. So there's 5 major studies there. This one in the middle here by Bodell is not an incidence study, it's more a analysis of ASA closed claims regarding drug errors. But basically, the top part of the graph here summarizes kind of the error rate per anesthetic. Looking at kind of the studies individually, this study was done by Dr. Webster and his group in New Zealand. It was a prospective study where they attached surveys to the anesthetic record and gave them to the anesthesiologist. And basically the anesthesiologist would fill out this survey at the end of their anesthetic, regardless whether an error of medication administration occurred or not. And they would return the survey back. If there was an error, there were additional questions that they would fill out regarding patient information, the type of case, and factors that they thought may have contributed to the drug administration error. And so this study was done from 1998 to 1999, and they had around a 72 response rate, which is not bad, and they found an error rate of around 1 in 133 anesthetics. This study was done in 2002 over the span of 5 years in Pakistan at a tertiary level care hospital. It was a retrospective review, so instead of a prospective study, they basically went back to their information reporting system. There was a database that they used for voluntary medication error reporting, and looked at data from that. And they found a rate of around 1 in 265. A similar study in Japan looking at retrospectively at voluntary medication reporting error. This was done over the course of 8 years, and they found a rate of around 1 in 450. And then this was a study done in Cape Town, Africa, similar to the first study here by Webster. They basically looked at prospective data, survey data from over the course of around 6 months using a similar study design, and they found a incidence of around 1 in 270 anesthetics of medication administration errors, but their response rate was quite poor, only 53%. And this is probably the best study out of all 5 of them. This was done at a tertiary care teaching hospital in the United States. It's funny when they do these medication error studies, they don't actually list the hospital that it was done at. I'm not sure why. But it was done at a major teaching hospital in the States. Similar study as the other prospective studies in a survey style, done over the course of a year. They had a 83 response rate, which is very good, and they found an error rate of around 1 in 200. So this just summarizes kind of the type of studies that have looked at the incidence of medication errors in anesthesia. And basically overall the error rate is around 1 in 100 to 1 in 500 anesthetics. That rate hasn't changed much over the course of 10 years. But a recent study in 2006 that was published in 2016 in the ASA journal Anesthesiology points to potentially some weaknesses in these previous studies. Some of the flaws that these studies could have include a poor response rate. For example, one of them was only 50%. And there are problems with voluntary reporting of medication errors. There's been studies looking at other medical errors not related to anesthesia or anesthesia medication errors, and they have found that physicians tend to underreport any sort of medical complications or issues unless asked specifically in person. So there could be an underestimation of the actual incidence rate. And as well, when we're actually giving medication, some of them may actually not be, some of these errors may not be realized, so there could be a lot of missed errors which would also affect the actual error rate. So is this rate that we're looking at, 1 in 100 anesthetics, resulting in drug administration errors just the tip of the iceberg, or is there actually more than we know? So this was what Dr. Kanji and her group from Massachusetts General Hospital wanted to look at. So this study they did at their tertiary care academic medical center, probably was the Massachusetts General Hospital, but it's not listed, and it's done by the group from Harvard over the course of approximately just under a year from 2013 to 2014. This was a bit different from the other studies that looked at medication administration errors in that they looked at prospective data, and they had actually direct observation in the operating room from trained experienced anesthesia providers, and they also subsequently looked at charts of all the cases that they observed afterwards as well to correlate their information. This center used a different system than ours. They used a codonics barcode assisted syringe label system, and they had both CRNAs, attendings, and house staff, which were fairly evenly divided in terms of numbers. The primary outcome that they looked at was the incidence of medication error, or ME, and adverse drug events. And secondary outcomes they were interested in were the incidence by specific patients, populations, or procedure characteristics. And in this study, pediatrics, cardiac, and out of OR were excluded from their study. The observers were quite vigorously trained, at least several hours of observed, practiced observations, and fairly specific case definitions as well that they had to understand. And surprisingly, it was quite a significant difference in terms of the rate that they reported. They found actually a rate of drug administration error in around 1 in 2 anesthetics and around 1 in 19 drug administrations. And so they were actually able to capture the rate per drug administration that these studies weren't able to in the past. This is a diagram from their paper, which is a bit complicated, but basically highlights the overlap of their medication errors that they found and the adverse drug event rates that they found. So in this yellow circle here, those are the numbers of medication errors that they either directly observed or picked up from chart review. And in this other circle here, these were the adverse drug events that they picked up in the same method. So out of 277 anesthetics, or 275 patients, there were around 3,600 medications administered, or between around 10 to 15 medications per case. They found that the rate of error, medical error, or medication error, or administration error, or adverse drug events per drug administration was around 5.3%, and that per anesthetic is around 45%, or close to 1 in 2. Around 1/3 of these, or this subgroup here, of medication errors resulted in an adverse drug event. 1/5, which is the stuff that's not double overlapped, resulted in little potential for harm. But almost half of the medication errors had the potential for harm. That's in this circle here. Only 4 out of 70 were intercepted, and the rest were not. And so over half of the adverse drug events that you see here were preventable. Of the adverse drug events that they looked at, none were fatal. 3 were life-threatening, 133 serious, and 57 significant. And so their definitions were pretty vague in terms of the seriousness of these adverse drug events. Basically defined life-threatening as any sort of event that could cause, if not treated immediately, the risk of death to the patients. For example, PVCs, 3 consecutive PVCs were what they listed. Serious events were defined as the potential to cause symptoms with a serious level of harm but not life-threatening. For example, forgetting to give antibiotics before incision. And then significant potential they define as, while harmful, pose little or no threat to the patient. For example, forgetting to follow up on a chem strip for a patient with diabetes. So this was the distribution of types of drug errors that they noted in their study. It's quite ironic that even using a barcode labeling system, labeling errors were the highest percentage of drug errors that they found. And actually a lot of physicians were apparently working around this barcode labeling system. And wrong dose was also second, which was similar to the survey studies that looked at the types of drugs errors. So next I'd like to look at some of the information presented from those previous studies on factors associated with drug errors. Are we distracted? Is the case too complicated? Are trainees more likely to make drug administration errors compared to experienced anesthesiologists? What about the time of day? Are they more likely to occur during after hours? So this was that study done by Cooper back in 2012, the last study of the survey studies that I talked about. And it basically breaks down the surgical specialty and the incidence of medication administration errors. And so the higher rates occurred amongst cardiovascular, thoracic, colorectal, transplant, vascular, and pediatrics with over a 1% error, a medication error rate per anesthetic. And the majority of these errors in pediatrics were due to drug dosing errors. That study from Cooper also looked at ASA classification and whether higher ASA class was associated with a higher drug administration error rate. And they found that with ASA class 3 there was a significant difference, although with 4, 5, and 6 there was no difference, and they attributed this to lower numbers of those cases being done. So these were compared to ASA class 1. They also looked at provider experience. So this hospital had CRNAs and student nurse anesthetists, as well as residents and consulting physicians. So these 2 red boxes are the 2 groups there, with providers in training consisting of the residents and the student nurse anesthetists, and the experienced provider group consisting of the CRNAs and the attending physicians. And they also found that inexperience was also associated with a higher rate of drug administration error. They also looked at factors leading to human factors that could contribute to medication administration error, and they found that distraction, haste or pressure, and misreading of labels was high. Surprisingly, fatigue was very low on their list. None of the drug errors that were reported in their surveys were due to fatigue, according to the physicians who responded. And looking at the types of drugs that were involved, muscle relaxants, antibiotics, opiates, and IV sedatives were the highest ones. So to summarize that study, they found basically a higher error rate associated with cardiothoracic, colorectal, transplant, vascular, and pediatrics, higher ASA, provider inexperience. They looked at time of day as well, but most of the errors actually occurred from 7 a.m. to 11 p.m., with very few errors occurring after hours. And human factors played a significant role as well. Back to that study by Dr. Kanji and her group from Massachusetts General Hospital, they looked at their own data as well, and their data was a bit different. So this is impossible to see, but to summarize that, basically, unlike the other study I just mentioned, they found no difference in ASA class. They found no difference in provider experience. They found no difference in surgical specialties. That being said, pediatrics and cardiovascular were not there. They also find that from their information, they found that things that seemed to be associated with higher error rates were long surgery, for example, those greater than 6 hours, or the higher number of medication administered, 13 or more. So I did a literature search looking at recommendations to reduce medication errors, and there's actually very little good quality evidence or high quality studies looking at various interventions and what their effect on drug administration error rates are. There are some guidelines and consensus statements, but very few RCTs at all. This was a study published in the British Medical Journal in 2011. It was done at the University of Auckland in New Zealand, and basically an RCT looking at around 1,000 patients, around 500 in each arm, looking at multimodal drug system, or it was patented as safer sleep, they called it. Basically, it involves kind of interventions in various areas of drug administration that they felt could lead to harm. For example, they felt there were labeling errors that they found, so they instituted a barcode labeling system. They had pharmacy involved significantly with pre-mixed syringes, and they also had customized drug trays, and they interfaced their system with an automatic information system linked to the barcode reader. So you could scan the syringe, it would populate your anesthetic record automatically, so you wouldn't have to remember charting when you gave the medication. And there'd be automatic reminders to redose medications and such. And they did find a significant reduction, or a reduction that was statistically significant in their drug administration error rate from around 12% to 9%. And that 12% is drug errors per drug administration, similar to the Kanji study, which their error rate was around 5%. And there are some guidelines that have been published, but most of these are based on expert opinion, case reports, and very little on RCTs at all. The two that I found were from the Anesthesia Patient Safety Foundation and published in 2010, and the European Board of Anesthesiology in 2017, both which were very similar. There actually are not really any guidelines that I could see from CES or ASA, and the only things that they mentioned in there were standards for labeling medications. So some of the guidelines that they recommended from the Anesthesia Patient Safety Foundation included use of barcode syringe labeling systems, preparing high alert drugs or frequent drugs in pre-mixed syringes from pharmacy. They also recommended standardized drug trays, and the most important thing that they recommended was establishing a just culture, basically a culture that was not punitive but kind of more educational and encourage error reporting to look at system errors that they can improve on. This is probably the most recent article published in the regarding anesthesia medication errors and ways to try to prevent them. This was a study published in the BJA in 2017. And basically it was a systematic review looking at the literature from 1994 to 2014. They looked at that body of evidence and did a literature search looking at specific terms. And they basically looked at each paper, and from each paper they extracted basically suggestions from either the authors or from the what the evidence implicated, and categorized these into various subgroups such as human factors, cultures and systems, case medication such as labeling and preparation errors, and cart inventory such as specific drug trays. And they gave each recommendation a grading or on a point scale based on the level of evidence. And they basically accrued all the points for each type of recommendation that they looked at, that they picked up. And so there are over 32 recommendations that they found, but these were the top 8. So it's very interesting that the top recommendation that they found was that culture change was very important, basically having a system to report medication errors that was non-punitive and supportive in finding system errors and educating physicians and looking at ways to change the system and how that error occurred. A lot of the common sense stuff that we would think about were on there as well, such as labeling every medication properly, reading and verifying syringes and drugs from the ampules, and color coding syringes. What was also interesting is they also found that barcode and scanners were often recommended, and using pre-filled syringes, which in other areas of medicine such as critical care and emergency medicine have been shown to decrease drug administration errors. So just to review kind of the objectives, basically we talked about the incidence of perioperative medication error. A lot of the old studies show an error rate of around 1 in 100, like we mentioned, but whether that's higher is still hard to know. There's only that one study that had very rigorous direct observation. We talked about factors that increased risk of medication errors, and we looked at some of the consensus statements on how to reduce perioperative medication error. Thanks very much for your time.